Good evening. I love it when the computer reminds me that I'm alive, that I'm live. Good evening. I'm Tanya Abreu, and this is the podcast Rethink Your Health. I've been in healthcare longer than I care to say specifically, but let's say more than 3 decades, particularly in women's health, but also bridging population health and men's health. And I will tell you that until I myself was struck dumb by late stage cancer, and I mean struck dumb, everything that I thought I knew about healthcare just went right out the window. And I realized that one of the things that we need to do every few years in our life, especially as we're threatened by disease or we feel at risk for something, is to rethink our health and to rethink our doctors and to rethink our providers and to rethink what we used to think was healthy. Because the most extraordinary journey I've been on over the past 2 years that I've been doing these podcasts, and this year, this last batch, we're on episode 42, I believe, with Kim Evans. I've learned that the best and the brightest healthcare providers constantly say, ooh, let's just rethink everything. Let's go back and reevaluate, reassess, because nothing in nature ever stays the same. So if you have low cholesterol, doesn't mean you're going to have low cholesterol forever. If your thyroid is functioning beautifully up into your 50s, doesn't mean you don't have to reassess. Tonight, my guest is extraordinary. She is a leader nationally, and she has helped literally thousands of women in person and digitally and virtually, and men too, find new ways to think about their health, new ways to not just psychologically and emotionally get healthier, but new ways of testing and new ways of assessing for, and she uses this word, optimal health in body and emotion, but she also says capital spirit and capital soul. So I want to welcome tonight Kim Evans, advanced practice registered nurse. There she is. Welcome, Kim.
Thank you, Tanya. It's such a pleasure to be here. I really appreciate it.
And I really appreciate you being here. And I wanted to know, since many of our listeners are not in healthcare, can you really talk a little bit about what an advanced practice RN is? And maybe a little bit, because, you know, we're hearing nurse. I mean, my primary care now is delivered by a nurse practitioner. I love my doctor, but I prefer her. We just have a better vibe going on. Talk to me about nurses and the kinds that there are out there that can provide direct care to us.
Sure. I'm always happy to talk about nurses because I love nursing. And, you know, the thing that nursing really brings to the table, separate from other providers, is that our training is more holistic. So we were trained to look at, just like you mentioned, body, mind, soul, and spirit, not just the physical body, because we know that nothing happens to you physically that doesn't affect you psychologically and emotionally. And many times, if you have psychological and emotional issues, it comes out in a physical nature. So, you know, it's really important to look at the whole picture.
And frankly, that has not been a part of any traditional healthcare model, correct?
That is generally correct. I think, you know, first of all, I'm an old-timey nurse.
I started when I was 5. Oh my goodness.
No, I'm joking, but you know, I've been a nurse since 1977, so that's a long time. And in the 80s, you know, the Holistic Nurses Association started a movement to try to bring in more holistic principles into everyday nursing. And it was successful in the 80s. You know, and again, the Holistic Nurses Association is alive and well. But in the meantime, what happened as healthcare moved to a commodity and a business, then a lot of the caring capacity has it's kind of, some of it's been thrown out by the wayside because, you know, the focus is on the electronic medical record and making sure that you get everything on that record so it's billable. And, you know, the care almost seems secondary. And of course, this is why I started my own practice in 1997.
Wow.
Because I saw in 1997, even way back then, that there was so much focus on just the physicality that didn't include psychological and emotional. And I couldn't be with it anymore. I was working as a critical care specialist, and I would look around the intensive care unit and think, you know, that could have been prevented. That could have been prevented. And then I
want to stop for just a moment because I put your website up on the screen because I have a lot. We're having a little bit of issue with internet connection. I keep getting waved on and off. I see 4 people on, then 0. I apologize to those of you that are not on, but I also want to let you know that this will be on all of the social media platforms, as well as on YouTube, Rethink Your Health. So if you're not getting all of this clearly, I apologize for the internet. It may be very well my home because they're building houses down the street and taking up cables, and it's just been messy, but I apologize. But I wanted to just underscore something that you said, Kim, and that is prevention. You said it about 4 times in 3 sentences. And I remember when I was reviewing your website, prevention is just absolutely key to the holistic model and absolutely key to what you do at the Institute for Integrative Medicine that you founded way before we talked about this stuff, right? Right now, people are paying for integrative medicine. When you started, I'm sure they thought you were a witch. So
You're right. You're right. I mean, when I very first started and decided to leave the hospital, I remember telling a nurse, you know, she said, "What are you going to do?" I said, "Oh, I'm going to do complementary medicine," because, you know, at that time, that was one of the terms that was used. She goes, "Complementary?" She goes, "How are you going to make any money if everything's complementary?" Oh. So I'm like, okay, that's not going to work. And then alternative medicine was the next term that came into vogue. And I really did not like that because truly what we do, you know, if a person comes to me and they're having chest pain, I'm not going to give them any herbs. I'm going to tell them, get to the hospital and have your chest pain evaluated. So I feel very passionately not to use the term alternative and to use integrative. So that really spoke to me all those years ago. And so
now it's politically correct to use that as a branch of medicine. There are medical schools that have integrative medicine tracks. That's wonderful. Wonderful. Let's go back to you do so much from the highest level, being involved as a leader in Nurses Transforming Healthcare, a national organization that wants to empower nurses to make changes that will save lives and improve preventive care and wellness health. You have an amazing, I mean, I fell in love with them. I thought today was Wednesday. That's why I asked you. You have Wednesday wellness tips from Kim. You can find them on, actually on LinkedIn, Kim Evans, but I'm sure they're also connected to the Integrative Medicine for You website. Talk to me about the different types of wellness tips you do every Wednesday and how that embodies the model that you work every patient with.
Right. Well, we started this 2 years ago when COVID hit, because I had so many patients who lived alone. And of course, they were isolating at home by themselves. And I just thought, we've got to find a way to connect to people. And so we started doing the Wednesday wellness tip. And so the first week we give a physical tip. And then the next week we give a psychological and emotional tip. And then the third week we give a spiritual tip. And we've just rotated those every single Wednesday. In November, it'll be 2 solid years that we've delivered our Wednesday wellness tips.
And that's great. I mean, if you do nothing else except teach your patients to every day, you know, we have weather. There's lots of reasons why the internet's blitzing, but the recording is not. So I promise you it'll be available. These three areas every day, if I say, hey, today, what am I going to do for myself physically? I'm going to go that, you know, extra 2,000-3,000 steps onto my 5. What am I going to do for myself emotionally? I'm going to reach out to my sister who I haven't spoken to for a couple of months and create a deeper bond. And then spiritually, I'm going to meditate. I mean, our mutual friend Leanne taught me how to chant. I'm going to do different things, right? So that I feel more spiritual. So I feel out of my body, out of my emotions, and closer to God. My goodness, Kim, if you can have all of us practicing that daily, it would be miraculous.
Yeah. Yeah. And
talk to me. Say I'm a new patient coming to you, and you do virtual care, correct?
We do.
Mm-hmm. Okay.
Yes.
So I'm a new patient. I'm coming to you. I'm going to give you some stuff. Okay. I'm not sleeping well at nights, 2 to 3 hours max. I'm jumping up and around. I'm type 2 diabetic, can't get it under control. I don't want to go on insulin. Blood pressure is normal. Cholesterol is normal. I'm prone to some panic attacks. This is kind of me. Prone to some anxiety attacks. I just really want to feel more energized and sleep better. And I want, you know, I want to lose 20 pounds. And I know this sounds like a miracle, but I'm willing to work at it. So I come to you, Kim, and I say, help me. So what do you do? What are the things you begin? How do you approach me?
Okay, that's really great. And it's not uncommon at all. You are like, what you just described is a very typical person who comes to see us, because many people have exhausted the conventional medicine route, or they've become so frustrated because, you know, they may see a cardiologist for this, or they may see a rheumatologist for that, but no one's putting it all together. We call it working the 5,000 piece puzzle. So this, again, that is very typical. So first, we do an in-depth assessment, questionnaire. Your first visit, we schedule about 2 hours. So that way we can, get your entire history. What has happened physically? When did it start? You know, what was going on in your life? And then we can also look at the psychological, emotional, and even the spiritual aspects. So we start there. And then we do review people's lab work. But so much of the time, I find that the lab work that people bring in, it's not in depth at all. It's very surface. For instance, what I mean, most people just have a standard lipid panel. So for instance, you said my cholesterol's normal. Well, is it? I would question
that. Same thing about thyroid. When we were before the show started, you said, Tanya, it's not about just TSH, this and that. Talk more about how you are an investigator.
So your cholesterol profile, most of the time, only the big 4 are measured. Total cholesterol, LDL, which, people, you can think of that as L, lousy, so your bad cholesterol. HDL, which is healthy. H stands for healthy, so that's your good cholesterol. And then your triglycerides. And that's end of story. But do you realize that 50% of the people who drop dead with a heart attack have a normal standard lipid panel?
Say that again, Kim.
50% of people who drop dead with a heart attack have a normal standard lipid panel. So that's insufficient to evaluate your cholesterol. So the first thing we do is do an advanced lipid panel, because literally there are 5 different types of the HDL, the good cholesterol, but we want to make sure you have a certain percentage of the good cholesterol. There are 13 types of the bad cholesterol. And if you have a high amount of the small, dense LDL, that's what can slip under that endothelial lining of the artery and set off that inflammation cascade, which can block your artery and cause a stroke or a heart attack. And then we measure all the inflammation markers, such as homocysteine, fibrinogen, LP-PLA2, myeloperoxidase. So we can really get a picture of what your cardiovascular health is.
Wow.
And then you mentioned thyroid.
Yes.
Mm-hmm. Yeah. So this is actually one of my favorite things to investigate because, you know, as I said, I don't know what has happened in conventional medicine, but most of the time, all that's looked at is a TSH, which is your thyroid stimulating hormone.
And there's two different kinds of TSH, because I just had this panel done because mine was like really low. Yeah. There's two, right? There's a TSH, two of them.
Yeah. But, you know, what's more important is that you look at again, if you're looking at a TSH, and it doesn't matter which of the two you're looking at or both, that is like looking at a peephole at first base and trying to make a judgment on the whole field if that's all you're looking at. So you got to get up in what I call the Goodyear blimp and look at the whole field. And so the full thyroid panel would include your TSH, of course, a free T3, a free T4, your total T3, a reverse T3, and then also your thyroglobulin antibodies and the thyroid perioxidase antibodies. So there's 7 parameters that we look at to fully assess a person's thyroid status.
Wow.
And okay. Over and over, I see this.
Yeah. So do you find people who come in who've said, I have a normal thyroid, I have normal cholesterol, and is it a high percentage that is not the case?
Yes. Yes, I would say that. I had one girl who came in. She was in tears because they diagnosed her with Graves' disease, which is hyperthyroidism, and they wanted to remove her thyroid and either surgically or irradiate her thyroid so that it no longer worked. And that was the plan. They scheduled her to take her thyroid out. And I'm like, whoa, 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 because all that they had checked was the TSH and the free T4. So I'm like, let's back up. Let's look at the whole thing. Well, it turns out no one had checked her antibodies, her thyroid antibodies. And her thyroid antibodies, these should be, depending on which lab you use, they should be less than 9 if you're using Quest or less than 34 if you're using LabCorp. Her TPO, her perioxidase, was 440. So clearly it was very high. And when you have a very high thyroid perioxidase, that's a classic symptom of Hashimoto's thyroiditis.
Oh, okay. I've heard about Hashimoto.
Yeah. So with Hashimoto's thyroiditis, your TSH can shift to hyperthyroidism or hypothyroidism. So, but you don't want to take your thyroid gland out. You want to correct the Hashimoto's. So anyway, yeah, I was beside myself when we got her labs back. But what I have to say is that she didn't have her thyroid taken out. She's not on any thyroid medication. And through managing her Hashimoto's, her thyroid antibodies are now coming towards normal.
Now, there's one other test I want to talk about. Welcome, Mr. Simard. Very cool. You're on a mission to empower NPs, APPs, and RNs to start their own independent digital practices globally. Very exciting, quite frankly, because what I've found in the few decades that I've worked with nurses is they really do think big and go deep. And, you know, I used to really be involved in women's cancer programs And I favored, when I had my own bout, finding women cancer NPs who worked with oncologists, because they would really go deep and try to figure out ways to ameliorate the cancer without killing me. Fascinating. But anyhow, I want to talk about one other test. Leanne Myers, once a nurse, always a nurse, podcaster, amazing person, told me that you changed her life with a test called APOE. APOE.
Yep.
Can you tell me a little bit about APOE?
I would love to. So the APOE, it's the gene of how we metabolize cholesterol. So again, you can't just look at a standard lipid panel, and it's so important to look at the APOE. So all of this work I learned from my colleague Pam McDonald, who wrote a book called The Perfect Gene Diet, who's done a ton of research on the APOE. But in a nutshell,
can you say the name of that book again?
The Perfect Gene Diet. And it's written by Pam McDonald. She's a nurse practitioner in California. Wonderful person. And I met her at a cardiology conference in 2003, and my life completely changed because she taught me about the APOE. We started doing it in Kentucky, and now we've helped thousands of patients with this. But basically, there's 3 different allele types: a 2, a 3, and a 4. And you get one from each parent. So there's 6 different possible combinations, such as a 2-2, a 2-3, a 3-3, 4-3, etc. So what is now known from science, and this is what's so exciting to me, is because it's based on science. It's not just, empirical, anecdotal evidence. It's all based on science. But these particular APOEs have different protein structures. For instance, if you have a 2-2, then you have 2 cysteine protein structures. What that means is that the fuel source for a person who has a 2-2 cysteine is healthy fats. So, in other words, one diet does not work for everyone. And so then if you look at the opposite side of the coin, if you have a 4-4, 4s have a very difficult time clearing fats and cholesterol from the body. So if you have a 4, then you've got to be on a low-fat diet. So the diet is completely different depending on what your genotype, what your APOE is.
Wow.
64% of the population have a 3-3. And if you have a 3-3, then that means you need some healthy fat, not too much, but not too restricted. So about 25%, 25% healthy fat. And, for years, we've been taught by the American Heart Association that everyone needs to be on a low-fat diet.
Mm-hmm.
And that's just not correct, because if you look at the APOE, only about 25% of the people need a low-fat diet. The rest need moderate fat or a high-fat diet.
And I've read recently, too, same with sodium, that some people restrict all sodium and they can be tested and they need the sodium to keep something viscosity, blood, I'm not sure. But I think it all comes down to something, damn, you've been working on since 1997, which is what I call personal medicine, personalized healthcare, where it's not rocket science, especially as we get into the genotype and genetic tests. And this is how I worked on my own cancer. Let me know how my cancer will respond to something before you give it to me. And don't tell me if I need to do something when you don't have proof if I need to do it or not, right?
Yes.
You're taking this to a wellness level that is so exciting. Can I ask how much the APO tests? Now, do you have, I think you're good, you're transparent. I saw prices. Like I saw $350 for an assessment, correct?
New patient appointment, yes, $350.
And that's 2 hours of kind of evaluation. Do we get tested prior to you? How does that work?
So basically, it actually now we've restructured so that it's 2 appointments, and they're each 90 minutes to 2 hours. So first you come in, we do your assessment. You meet with one of my nurses, Betty Griever, and then we put our heads together, and then you come back in and we give you an entire treatment plan all written out with the next steps of what you would need to do. And both of those appointments are included in the $350.
Wow.
So we really have made it as affordable as possible because, you know, I mean, think about it. I started here in Kentucky and we knew there was going to be resistance because we don't take insurance. It's a cash pay practice. So we knew that a lot of people would be resistant to a cash pay 20 years ago. It's a lot better now. But, you know, at that time, people were a little bit resistant to that. But
they still are.
Yeah, yeah. And rightly so, because with the astronomical rates that are happening for health insurance, I feel the same way. If I'm going to pay all that money for health insurance, then let me use my health insurance for something that's valuable.
Well, you know, what's interesting is I sat on a webinar that talked about this real trend. It used to be like fringe for poor people kind of trend, but this real trend with everybody to just carry catastrophic health care.
Yeah.
And then you take your $10,000 a year and spend it on the Kim Evans of the world, on retreats, on healthcare, on supplements, on things that you get results with, right? Yeah. And the catastrophic, which is still going to cost you a couple grand a year, is going to cover surgeries, is going to, you know, and like crazily, Kim, I'm sure you have the same experience. If you want to get an ultrasound of my thyroid, if you bill my insurance, it's $1,000. If I cash pay, it's 180.
Yeah, I had that. I
mean, go figure this.
Yeah, I've, you know, I put a lot of this in my book.
Oh, I'm going to put that up. Go ahead, keep talking.
About, you know, the catastrophic healthcare and that same concept about, you know, so you direct your healthcare spending, which I think is very empowering and very, very good.
Yeah, yeah. And so I just put on the screen.
Yeah.
Sorry, go ahead. I interrupted you. I apologize.
Oh, no. So what's happened since then is that now the Transparency Act has passed. So now any lab, hospital, any procedure that's going to be done, they have to tell you how much it's going to cost before you have it done. Now think about that. There's no other business that has ever been in existence where you would not tell someone what it's going to cost them before you actually do the service. How this has happened.
Never thought of it that way.
Oh my gosh, how this has happened in healthcare all these years. I just don't know why we've put up with it and why we've allowed it. But
Kim, I am having a hard time looking at the last. It's Kim Evans' book is Transforming Healthcare, You, Me, and the Broken.
It's healing you, me, and our broken disease care system. So.
Wow. Okay. So talk a little bit about this book, who you wrote it for, what you think, and it's on Amazon, guys. Yes. What you would like to have happen with this.
So the book, first of all, I wrote it, you know, before COVID, so I could rewrite the whole thing now since COVID, because, you know, so much has happened since then. But I think at least it gives people an idea on how healthcare could be. And again, based on personalized medicine. And then I do describe several of the tests that I've talked about, the APOE, the advanced lipid panel, and give clinical examples of why that's so helpful and so important. So, and then there's a chapter on how we can transform the payment structure. Now, I need to rewrite this book again because, as you know, since I wrote the book got me connected to Leanne Meyer, Once a Nurse, Always a Nurse. I was a guest on her podcast. And then when she found out my passion to transform healthcare, she said, oh, you have to connect to John Silver and to Kathleen Bartholomew. So we all connected, and the four of us started Nurses Transforming Healthcare.
What is the website for that again? It's Nurses Transforming Healthcare, right?
Yeah, it is. .org. And John Silver, who is a nurse, he has the best idea on how to transform healthcare. And that is to shift healthcare to a public utility model. And so if we did this and we had a public utility model for healthcare, then just like you would pay your gas bill, electric bill, water bill, you'd pay healthcare. So you would have one cost that you pay every month based on your zip code. And then all the care would be orchestrated, all integrated, and the care would be orchestrated, managed under nurses, or at least people who have a more integrative approach to health.
Interesting.
And so, and it would, we would flip it around and base it on wellness and disease prevention. Mm-hmm. So the cost would decrease dramatically, because if we're preventing things instead of waiting till you get sick and then trying to fix it, we could significantly impact healthcare.
And I'm thinking about models that I've kind of learned about. You know, we talk about the blue zones, right?
Yes.
Those 8 areas of the world where disease is rare and longevity is common. Actually, you know, the majority of people live to around 100 years old, and they live without chronic disease. And, you know, the things that they do share, I think are so easy, right? When you really think about it, clean food, no processed food, easy ingredients, lots of rest, clean air is huge, environment is huge, and then family and community structure.
And a purpose.
Right,
they
right.
all
yes.
have a purpose for their life. So that's another important key feature.
Yeah. So it's really fascinating that as a country as rich and intelligent and evolved as ours, that we really are, as you put in the title of your book, a broken disease treatment. You know, it's like a factory for disease.
Yes. Yeah. Well, the one thing,
say it's because we can make money, but I don't understand why we can't flip it, and pharma can make money by selling drugs that keep you healthy too.
Yeah.
Because aspirin should be really, really cheap because they're, you know, willow bark. But when you get one in the hospital, they're like $40.
Yeah.
So, you know, we could do the same thing with good vitamins. I don't know, but it shouldn't be this difficult, right?
Yeah. Well, that's what intrigued me so much about John's public utility model, is that he taught us that the country has had a similar problem before. What I didn't realize is that in the 1930s and the 1940s, electricity was not a public utility. And, you know, the electricity was in the cities and the urban areas, but it was not available in the rural and the suburban areas. And so then President Roosevelt said, this is not right. Electricity should be a public utility available for everyone. So the country has done this before.
But it's not socialized. Like our electric companies, it's not a socialized system.
No, it's not socialized medicine. Not at all. Because it's going to be a transparent system. And then the model that makes it different is that everybody has a stake in it and everybody contributes to it. So for instance, local businesses contribute, the individual contributes, the state government, the federal government all contribute, but the cost is significantly lower than what we are experiencing now.
That's amazing. Is there a white paper on this available anywhere that you know of, Kim? John?
Yes.
Let's put John's name up here so people can find him on LinkedIn. It's John
Silver.
Mm-hmm. Silver or Silvers?
Silver.
Okay, good. Well, that's fascinating because, we do know, and I don't know if those that are listening and watching tonight know this, but truly, hospitals are closing at an alarming rate. Alarming. Not only are nurses and doctors leaving, nurses by far have disappeared. There's a nursing shortage in 2024 of 1.6 million physical beings gone. Mm-hmm. You can bring up all the 18, 19-year-old LPNs that you want, and they're not going to provide the same level of care of a woman or a man with 40 years of nursing watching over. But in any event, what we're finding is there's this amazing dearth of professionals. And more than that, I mean, urban hospitals, Atlanta, Cleveland, especially the charity hospitals, gone for the at-risk populations. And so where is the public utility? Where is, for all the years I've been in healthcare, everyone talks to me about population health. Who's caring about the population?
Yeah, it's a great question because, we looked and this is not just unique to certain areas, but for instance, Leanne was showing us that in rural Minnesota, there were hospitals that were adjuncts of Mayo Clinic that closed. And Mayo Clinic, of course, is a non-for-profit institution, but these areas that were closed because they were not profitable. So now you have a double issue because you have, rural areas that have no access to healthcare at all. So that's. So Tanya, your audio is cut out.
I'm sorry.
Yeah.
I was just saying. Oh, Jackie, I don't know you. Thankfully, LinkedIn is being very consistent tonight. But all I do know is that these poor pockets where there were hospitals, those hospitals are going. I mean, they're shutting their doors. I spent a long time in Cleveland, and I knew Cleveland Clinic very well. It's the elite system, although they've posted that they're going to also be doing huge cutbacks because they're posting in the billions a loss. But St. Vincent's, which was the charity hospital, which was the hospital for all the poor, and there are a lot of poor in Cleveland, is closing. Boom, bang, done. They're going to have ambulatory care, and if you need acute services, head on over to the clinic or somewhere else. We can't do it anymore. So this whole concept, and Leanne's giving us some background too, of this public utilities, it scares people whenever you say something like that, because I don't know, everybody, you look at some of the best medical systems in the world, including Japan, including Germany and Sweden and Canada. Yes, when you have something really weird, sometimes it takes longer than it should, but at least you can get healthcare, right? There was a time here in this country just 4 years ago when I lost my commercial health insurance, and I am diabetic, and I was under amazing stress, and it all got so bad that I, had to go to state insurance, clinical care, Medicaid. I wouldn't go. I refused to be treated the way that I was being treated at a city medical clinic, right? I didn't deserve that. And neither do the millions of Americans of all races, of all ages. No one deserves that.
Yeah.
Just like no one deserves not to have electricity. So this is absolutely fascinating. That's why I love nurses.
So one idea that we had is to, and just like someone mentioned about the neighborhoods with lower incomes, what if we created mobile health units that could go into those areas and take the care to them? So that's one proposal that we did propose through the Nurses Transforming Healthcare for those rural areas in Minnesota, is to create a mobile health clinic run by nurse practitioners. And our proposal was to test it for a year and have 4 different rural areas. And so the mobile clinic would go for 1 week per month for the entire year and then rotate to the next area. And then if someone needed something beyond that week that the mobile clinic was in the area, then we could do telemedicine or telehealth. But
right. And there's such an amazing change. I mean, Medicare just this week sent out hard copy letters as well as emails to every billing physician and healthcare provider in the United States saying, hey guys, we'll pay you for chronic care management now. We'll pay you to keep people out of the hospitals for the first time ever. Please use it. Only less than 1% of people with 1 or more chronic diseases over 65 are being managed by their providers.
Wow. That's a shocking statistic.
But it came from Medicare, and it said, docs, get on board. Let's go. Yeah. And it's all set up. I mean, I work with different clients. I have one client who has, CCM, chronic care management, just ready to go to any doctor who wants to use it and be able to really monitor their patients. But it's not in our MO. It's in yours since 1997. It's like Big Macs, right? But it's not even in the young people coming out of medical school. They're going in, looking at a person and looking for illness.
Yeah. Yeah. And they're looking for illness in the narrow scope of their specialty. And then if anything deviates from that scope, it's like, okay, we need to refer you over here to this specialist, or refer you over here for this specialist. And then you have somebody going to fragmented, specialist, and no one's looking at the whole picture.
And that's what you said earlier. Health is about going wide and digging deep, and using the technology and the tests that are available to us to personalize a wellness journey for everyone who comes into your practice. That's, I think, really exciting. I gave information, I'll do it again, on how you can get in touch with Kim. There's a couple of reasons why you might want to get in touch with Kim. One is to just begin a personalized journey of care. Two is to just talk to her about whatever healthcare business you're in. I mean, she's an amazing consultant. She's just been around in this industry and trying to make people well longer than anybody else I know. So that is really cool. I wanted to ask you, though, I'm going to come back to us as personal people on here. If you were to say what the top 3 determinants of disease are for your patients, the top 3 things that you constantly harp on people about and want them to change, and know that if they do change these areas of their lives, they will feel younger, stronger, more energized.
Yes. Well, a huge piece of that is nutrition. And because part of the tools for integrative medicine, diet and exercise. Now, all of us know we should exercise every day, but how many people do 10,000 steps a day? I mean, this was my husband, Dave, and I, this was our COVID strategy. We took on that we were going to do 10,000 steps every single day. And we did it for a solid, 19 months. So, I really think exercise is key. I also think diet. And again, remember the APOE, that's a good key to show us how to eat specifically for a person's genotype. But beyond that, even if you don't get your APOE checked, how do you create a healthy diet? Because our food system has become so toxic with processed foods. And so, we make it really simple. If you just eliminated high fructose corn syrup, hydrogenated oils, And then for the top, many people are familiar with the EWG, the Environmental Working Group, that lists the Dirty Dozen and Clean 15. So if you just if you looked at the Dirty Dozen and made sure that all of those foods that you consume only organic versions of that, you could significantly improve your diet. So much.
It seems like simple guidelines.
Yeah. Because, the top three, number one is obesity. And if you look at the obesity statistics in this country, again, it's alarming, because when I was in grade school and even high school, there were very few people who were overweight. But now if you look at an average classroom, up to 35% are obese. Mm-hmm. And these are children. Mm-hmm. So, we used to call diabetes adult onset diabetes. They've taken off the adult onset because so many children now are diabetic. So we know that obesity leads to a diabetes epidemic. We know that diabetes epidemic can lead to heart disease. And now we know that through the obesity, diabetes now also leads to Alzheimer's.
And cancer.
Yes. So, obesity, nutrition, diet, and exercise is the basic thing. And, why do we not have more information on this? Well, if you look at the education for medical providers in nutrition, it's, most of us did not get trained in nutrition. And in the average medical school, their nutrition education is 30 minutes. And most of the time, they're just taught when it's appropriate to order a registered dietitian consult. And then
even registered dietitians that I've gone to for diabetes, they say now you need to get enough protein. You need to, it's all about protein, carbs, calories, but it's not about the chemicals or the organic nature of things or good fats, but none of it's covered because, it's, I guess they don't know.
Yes.
All right.
Well, people make a comment that,
this is so good for us.
I'll say that a lot of times my patients complain about organic foods being so expensive. But, what's interesting is that you can find local farmers. And of course, we highly advocate supporting local farmers. Mm-hmm. Because, if you get to know your local farmer, then many times those foods are much less expensive, so that you can eat healthy and still stay on a budget.
Yeah, no, that's true. And sometimes, like I did, I got an entire basket of eggplant that I'm going to make in Russia, we called it poor man's caviar. You chop it all up with some onions and some olive oil, and you can put it in your cupboard forever. But I got an entire basket for like $3 because it's the end of the season. They're going. Number 2 and number 3, for the sake of time, I need to get this from you because I love things.
Yeah. Yeah. So obesity, which really, I just said all 3 of them, because obesity leads to diabetes, which then leads to heart disease and then Alzheimer's. So, those are the top killers in the United States. And then the other thing that I see that's not necessarily a killer, so to speak, although depending on which women you talk to about it, but that is hormone and menopause issues. So, and many times the thyroid problems and the hormone problems go together. And when we drop our estrogen levels, that affects our thyroid. And so then many people hold on to weight, especially in the middle. So that, again, becomes a big issue. And so do
you do bioidentical hormones as a part of your practice as well?
We do. Only bioidentical. I would not recommend conjugated estrogens or, pharmaceutical, the Premarin, etc. But backing up, how do you assess that? so the one great assessment tool that we've used for hormones is Precision Analytical. And that is a urine test that will tell us what a person's cortisol levels are at 4 points during the day, and then also their estrogen, but not just their estrogen. It also shows all 3 estrogens, and then how you metabolize your estrogens. Because it's one thing to, replace the estrogens, but if a person's not metabolizing the estrogens normally, then you don't want those estrogens recirculating over and over, because that could be a risk for breast cancer. Mm-hmm. So it's critically important to assess that whole entire adrenal and hormone picture.
That's amazing, because, one of the things that, kind of in my own life and in my circle of friends who are all between 50 and 60, everyone's like, oh man, I never thought that I would lose my sex drive, or I never thought that I'd be lazy like this, or I never thought. And then, I always say, why don't you go get your estrogen level? I mean, your hormone levels tested, your testosterone, and then they go on bioidenticals, or they go on testosterone pellets or anything. And then in 3 weeks, they're like, oh my God, I feel like I'm like 25 again. This is amazing. My hair is better. My skin is brighter. And yes, it's not 100% natural, right? But if we were living in those blue zones, the foods that we eat are naturally more rich with the components that feed our endocrine system. Right. Yeah. And so you keep your hormones, like my Italian side, right? My grandmother, those in my family that lived into their early 90s, late 80s, women, they weren't withered. They weren't dry. They were olive oil, estrogen filled women who had very vital lives. And so, I just think that what you brought up at that last minute of our conversation, if you want to reach out to Kim, because what I'm finding, even in my own cool circle of doctors and nurse practitioners I use, they'll say, oh, Tanya, we're going to put you on estrogen. I'm saying, a natural estrogen, a bioidentical. And I'm like, no, wait. Can we just test me first?
Right.
Test me first. Because I have negative testosterone. And perhaps if we fix that, then the other stuff falls into place. Yeah. But they don't, because most of the providers, even the women, have learned, okay, certain age, natural estrogen better than, synthetic. Let's just prescribe that. And it's not like you do that test. And this urine test, right? So I can call you and you can have this test sent to me. I can do it, have it sent, then you can read for me.
Yeah. We can actually drop ship you. We can order a test kit to be drop shipped to you for Precision Analytical. And then you just do the testing, and then we get the results. And then we set up a phone conference or, Zoom or whatever. If you're close, come in.
Yeah, man, it might be worth just flying into Cincinnati to come see you. I've been threatening to do that. Louisville. Yeah. Right. Yeah. But wonderful. Well, listen, I have to ask, I have more questions. I'm sure people do. I'm getting texts. I'm very excited. We'll have you back. We'll talk about something, but I want people to get in touch with you. I am putting up the number again. I'm sure your office team can, after so many years of being in practice, coordinate a great virtual experience for anybody that wants to reach out. But I have a question, and I ask everybody that gives me the honor of being here. I'm so grateful. And the question is, Kim, fill in the blanks. I once thought that health was blank, but now I know it is.
I once thought that health was the absence of disease. But now I know it's actually achieving optimal health of mind, body, and spirit.
That it is achieving optimal health in mind, body, and spirit. I had an amazing Johns Hopkins gynecologist tell me that it was a woman, and she said, I don't know what the outcome's going to be, right? This all looks really bleak. And I know somebody told you 6 months. She said, all I know is I'm your doctor now, and I'm going to optimize your health.
Yeah.
Optimize it. Cancer cells and all. We're going to optimize it. And I'm like, what? You know? And, you know, she said, we're going to do this surgery and I'm going to tack up your bladder. So for the next 30 years of life that I'm assuming you're going to have, I mean, she was just amazing. She was amazing. And that's what healthcare is about, right?
Yes.
Giving people hope, optimizing what they have, right?
An image. She gave you an image that you're living the next 30 years. So that's what you're living
without incontinence.
Yeah, that's what you're living into. So, and that's so important.
Yeah.
So important.
Well, Kim, Leanne Meyer, who has said a few things here and has introduced me to what I call my lifelines, mostly nurses. And the weirdest thing has been happening. And I see Susan, I got to put you up here, Susan, because like her on LinkedIn, I actually have the most incredible nurses reaching out to me now. Just hi, Tanya. And it has made my life and my health truly better, truly optimized. And if I have a problem, I know where to go. I know where my next steps are going to be for a deeper dive for my longevity, for my femaleness, for everything. And that's with you, Kim. You are a traditional healthcare provider. You're not woo-woo. You're not 30 years old that just got all these ideas off of LinkedIn and a couple of, you know, seminars. You're somebody that has seen literally thousands of people undergo optimal health under your care and in the world of integrated medicine. So I have amazing, amazing respect for you. And oh, look, I have to put this up because I like that. I don't know who it is, but it's somebody on Facebook who thinks I rock. I think you rock too. I just wish I knew who you were. And Jackie, you have been a joy to have on this show. I hope you follow through. Please let me know who you are on LinkedIn so I can kind of bring you into our groove. Once again, Kim, I appreciate you. You are a gift.
So look for the Wednesday wellness tip tomorrow. It'll be on Instagram, LinkedIn, and Facebook.
And your LinkedIn, oh, hi, Sky in Vegas. Thank you, sweetheart. LinkedIn, and you are Kim Evans, right? There's no middle name?
Yeah. Right.
Kim Evans, APRN. Just go ahead and put that in. Get into the LinkedIn for Kim, and you won't regret it. They're very fun. They're very meaningful, and you dress like a rock star, Kim. Not to put the pressure on you. Anyhow, we've had our full hour. It's amazing. This was such a blessing. Thank you, everyone that got in despite some of the internet. This will go up live on all the social media platforms as a pre-record, but then it'll also, I have to ask people to go subscribe. Rethink Your Health is on YouTube. And if you go there, you'll see lots and lots of our podcasts. And you'll also be notified when a new one comes in case you can't join us live. Thank you. Have a healthy, happy, hopeful week. I appreciate you. Bye-bye.
Thank you, Tanya.
You're welcome, Kim. Thank you.
Bye-bye.